Welcome back to the video 60 of the Staying Healthy During COVID Epidemic. This video, I'm going to explore the discrepancy of the estimated versus the reported deaths of COVID-19, especially in tropical countries who are reporting very, very low rates of incidence and death rates. I'm Professor Sunil Wimalawansa from New Jersey, the United States of America. Please feel free to press the subscribe button so that we can create more videos to help understanding the process as we progress. So let's explain some of this, explore some the explanation. Except in Singapore, South Korea, the rate of PCR testing in South Asian countries are extremely low, approximately 5% of what they're supposed to do, in fact, compared to the West. Moreover, none of these countries are carrying out community testing. So you are missing 85% of the people with COVID-19 who are asymptomatic. Where, in fact, the majority of these deaths also occurs and during the lockdown and especially the prolonged curfew period. Therefore, the majority with COVID-19 patients in this country were not diagnosed, or true COVID-related deaths are not included in reported statistics. If you don't do PCR testing, you cannot and you will not be able to diagnose a person with COVID or person who died from COVID. Due to too fewer PCR testing and inferior quality of PCR kits they use, less diagnoses are made in both alive and in deceased, especially in peripheral hospital and even in the central large hospital, especially in those who are dying at home because they were unwilling to go to hospital under these curfew conditions. Considering the above, the number of deaths reported due to COVID-19 as mentioned in my previous video, the video 59, anything from 10 to 40 times less than the real numbers. So meanwhile, the doctors, nurses and public health personnel like PHIs in all countries working their best to help people. At times, like in UK, even risking their own lives. So we need to recognize their effort and the lack of efforts from certain degree from the politicians and the administrations of implementing the right policies and doing the right things for their constituents. However, without sufficient testing, authorities are clueless of what is going in the community and consistently, therefore, fail to leverage the data for strategic planning. So there's no real data, and rely on the hospital-based statistics alone, you are going to take inappropriate actions. In fact, many of these tropical countries do not have useful, effective, or tangible statistical planning or action. Meanwhile, the senior administrators will totally rely upon the curfews to cure the problem of COVID, as if the COVID-19 virus understands the curfews. Moreover, the number of PCR positive people, the people treated in hospital or ICU are skewed, that cannot be taken as markers on how a province, district or country is managing the disease. This again is very much misleading. In the presence of meaningful number of PCR testing, as done in South Korea for example, positive cases are only generated to the community and hospital. If you don't do it, the positive cases are only come through the centers, the large hospitals and through acute admissions. PCR tests are in fact performed only in a small minority of the fraction even in these hospitals. So yet again, we are another barrier to diagnosing COVID-19. In addition, without doing any community testing as in Sri Lanka, India, Indonesia, etc. How can we categorically state the acute number of COVID positive patients in that country? The administration must admit that their figures are misleading and erroneous. Those numbers are misleading, especially for global community like WHO planning and advising various global policies. Authorities have no way of identifying the over 80% of the asymptomatic but infectious people in the community, not helping them to prevent the disease spreading to others. Many older patients admitted to hospital, even with respiratory system, despite claims, are not tested for COVID-19. Are therefore related deaths and admissions are not accounted in reported country statistics. Perhaps such faulty statistics by health authorities are designed for local and political consumption, or perhaps is due to lack of funding. It's up to the country and the people to decide whether this is the genuinely lack of funding issue or political issue. These are unreliable and markedly underestimate the prevailing deaths, unfortunately misleading the global countries. For example, 90% of the COVID-19 death occurred even in the warmer countries like Australia, were mostly housebound and institutionalized elders aged above 75. They were grossly vitamin D deficient and they had multiple comorbidities, and once they got COVID-19, there's no way they could have the immunity to fight against and recover or overcome from COVID. They almost like 95 to 98% of them had a chronic cardiovascular or pulmonary disease and extremely low serum 25 hydroxy vitamin D concentration, the marker of vitamin D sufficiency, and thus a significantly weaker immunity. So it's meaningless trying to compare deaths in small island nations like Sri Lanka, Maldives, etc. with the U.S.A., U.K., Italy or Australia. That's deceiving. So the next video I'm going to talk about the expectations during the summertime and coming winter. What is going to happen with COVID-19? Till then, thank you. Don't forget to press the subscribe button. Have a great day.